So what is an invagination or what is intussusception? Who ready to answer?
Is
Yeah.
interception
Please.
You go on, Cap.
when the bowel like goes in almost, so it like folds over itself? For
Folds
interception,
over itself.
as in, I don't know how to explain it properly, but like the
It's
bowel
turned
is
inside out.
Okay.
It's like when one section of the intestine goes into the other one, so they like overlap each other basically.
Correctly. So that's when the intestine folds inward itself like that. I found a good description that the students using is a telescoping of the intestine one to another one. It's when there is literally its egg behaving as a telescope enters one into another one like that.
Doctor, isn't that intussusception? I thought we were speaking about
Intussusception,
invagination.
intussusception, and invagination. It's synonyms. It's two names for the same thing, just depending what point of view are you talking about. It's the same thing. Or you met some difference between them. Intussusception.
I was under the understanding that intussusception is when you have this telescopic, so when it's actually folded in, so two organs could be blocking each other.
Yeah.
But then invagination would be when it's just, say, like mid-cavity, or there would just be a folding in on itself at another point.
No. It's the same. It's the same in Russian. We don't have the name. In Russian, we don't have the name intussusception. We have invagination, invaginaция in Russian. But in English, they suddenly decided to change the name of it. I don't know why. So we're stuck at that point. So one intestine enters into another one. Okay. At what age that usually happens?
Between 4 and I think 10 months. 4 and 10.
4 to 9 months usually.
Oh, nice.
But that's like usually, that's focus your attention. That can happen as earlier as later. It literally depends on the process of fixation of the intestine in the proper place. And well, I met the invagination in the case with a lady above 30 years. And again, the invagination that I draw over here is the classical place for invagination. It can happen over here. It can happen over here. It can happen anywhere in the small intestine. So this one is just the most classical place, the ones that described in the books. So let's stick with that. Okay, 4 to 9 months. Good. That's the average. So we're talking about infants right now, and you need to focus your attention that that is infants. They cannot talk, they cannot express themselves, they cannot explain nothing. So that's why it's a bit difficult to diagnose, but possible. Why this is happening? What's the etiology? What's the etiopathogenesis?
Can it be because of the Meckel's diverticulum?
Presence of Meckel's diverticulum is one of the, how would I say, one of the factors that will increase a chance to get invagination. But etiopathogenesis actually in this process, it's a combination of factors. It's a combination of factors that's supposed to all come at one time. One factor, lymphoid tissue edema, some kind of infection, some kind of virus, some kind of reaction of the lymphoid tissue. Lymphoid tissue of the intestine becomes to swell a bit, sometimes not just a bit, a lot, and partially involved in the process of peristaltics, bothering the process of peristalsis. Second factor, this is the time, 4 to 9 months, is the time when we do what with infants' diet?
I think 4 to 9 months And when you're trying to wean the child off breast milk, so you introduce the child to other liquid diets and all.
So you start to add some kind of supplements, right?
Yes, yes.
So getting ready the child to, because the breast milk is not enough already and you need to feed more something. That's true. This something that you give to the child will be recognized by his organism as something new and foreign and possibly dangerous. That's why his GIT will react on this one with a particularly pathological effect. I can't say that it's completely pathological, but it can react with hyperperistaltics, too powerful movement, and combination of lymphoid edema plus hyperperistaltics. And as I told you before, the children have really soft tissues. Connective tissue is also not so strong as in adults. So intestines are not fixed properly and not fixed completely. The intestine can, with a peristaltic wave, protrude one into another one because they can recognize that these lymphoid tissues could be a piece of food, and it can bring it inside. Another reason for invagination is the internal polyp. When the polyp inside can be recognized as a piece of food, the intestine pushing it in and inverting one layer into another one, proximal part of the intestine into the distal part of the intestine. So that's how it goes. Hyperperistaltics causing invagination in children of this kind of age. What kind of what is the clinical picture in this case? How the child?
Abdominal.
Yeah, please.
Okay. Vomiting.
Okay, vomiting.
Yeah. In diarrhea and mostly some of stool mixed with maybe blood or mucus.
Okay, so blood gives you jelly-like stool, and that, guys, please focus your attention. This one is the most important sign in this case, jelly-like stool. It's really specific, extremely specific for this disease. How this stool appears, where the blood comes from. You know that our intestines supplied by the blood by the mesenteric veins and arteries and vessels, right?
Yes.
Yeah. And the invaginated part of the intestine as well will have to be the invaginated part will require the blood supply as well. But as you can see, as I draw, if the invagination will go in, it will fold the mesenteric arteries with it. And it can happen that we will have particle blockade for the blood supply in that area, especially in the time of peristaltic wave. The intestine moves a bit deeper, blockade appears, then the peristaltic wave goes away, blockage open, and the blood supply restored. But there can happen that edema, inflammation, and periodic ischemia will cause inflammation in the distal part of invagination, and the blood can evaporate through the walls of the intestine into the volume of the intestine. As a result, because the food cannot pass through the intestine, it cannot pass through the intestine, it will not be in a stool, but the blood will. And with the blood, we have what? We have mucus, as you said, that's constantly produced by the colon. As a result, at the exit, the stool will have jelly-like consistency, red jelly-like consistency. It actually, guys, looks as a jelly in real life, but it smells like stool, but that's why you don't want to try it. Trust me. Usually nowadays parents brings the child to the hospital with a photo of the problem that they discovered. If in the past they try to describe it by their own words, nowadays they show you the photo. That's how the blood comes from, and the jelly-like stool appears. Good. What other clinical signs do we have?
The pain, so it comes in peristaltic waves.
Pain that comes with peristaltic wave. So what else did you said about the pain? It is associated with peristalsis, but that's not all. The child cannot say that he feels pain. So you need to mention about the fact how he represents it, because this one is also really specific. Who wants to specify the pain?
I'm not so sure, but I think the pain is going to be colicky and intermittent.
Okay, how the child will represent it.
So because the child cannot say anything, maybe he's going to become really lethargic and cry a lot.
Cry a lot. Okay.
Would it be on palpation?
Come again? Come again, repeat please.
On palpation, so if you're touching the area, if the child
No, and the trick is that palpation is painless. That's the differential diagnostic with appendicitis. Even if that happens in the right iliac fossa, you palpate the tubular-shaped object inside that is soft, elastic consistency. In case of appendicitis, that will be really painful. In case of invagination, that will not be really painful. I will add like that. Usually. Okay, so what about the pain? It's also specific. It's also specific. The child will represent it with a specific kind of clinical picture, with a specific kind of behavior. He will be restless. He will be crying. He will cry, scream.
Doctor, would the child be pulling their legs up, like drawing legs up in a certain position?
It will be. It will be. The thing is that is not always.
Okay.
Because in this case, we're talking about the condition of it's intermittent pain. Colic pain in the description is intermittent pain. And intermittent pain in this case will be like each 10, 15 minutes and duration for like 1 to 3 minutes. So the child, he's too young. He don't understand what's going on with his body, and he feels pain inside that appears suddenly and suddenly disappears because of the peristaltic wave, as you said. So imagine yourself a condition. Child sitting, playing with his toys, doing his own business, then suddenly he is falling down on his side, brings his leg to his abdomen, starts to cry, to shout, and becomes really, really restless. But with time, he, like in a couple minutes, he relaxes, stops crying, sitting back and continue to play with his toys. And this kind of condition repeatedly appears from time to time. That is specific kind of behavior for the invagination. That's the second kind of thing that you do definitely need to remember. Oh my God. Okay. What else in his clinical picture? It will be vomit, guys. With the vomiting, we have another kind of thing that going on with the vomit. It's called dehydration. Right? If the child has dehydration, he will have, if the child has vomiting, he will have dehydration. What does dehydration do with the child? What kind of clinical picture will be in case of dehydration? How will we recognize dehydration in an infant?
They'll be weak.
Come again? Repeat, please.
I said the child will be weak, and like I said before about lethargy.
Okay,
if a
weakness,
child is
lethargy. Okay, what else?
Pale. I think the child will be pale because he's
Pale
dehydrated.
skin, well, that will be referred to bleedings. No, dry skin, then yes. Dry skin and necrosis.
during clinical examination, there will be like a sunken fontanelle.
Correct. Guys,
sunken.
that correctly. And one more thing is no tears when crying. Oh, no tears when they're crying. Okay, what else there will be in clinical picture? What else the parents or the mother will tell you about during your interview?
They'll have very less urine and it will be very
Oh
yellow.
yes. Sorry, I forgot about that
Colours.
as well. That will be with the dehydration as well. Yeah.
So would the mother say that the baby's not taking any food or?
No, he do, but like he vomited out, and generally, you forgot about one important thing, guys. What have
There will be a fast breathing. The mother can say that the child is breathing fast, or maybe there's a respiration and the heartbeats.
No.
I think no. In dehydration.
That's supposed to be really severe dehydration.
Okay.
Constipation, because the food cannot pass, you will have constipation. Instead of constipation, you will have red jelly-like stool. So these two things are combined. Okay, that is the clinical picture that the child will have in this case. And as you can see, we have two serious symptoms that the child will have in this case. Now you imagine yourself a case, now you imagine yourself a condition of a child that you have. We will follow to the physical examination. During your physical examination, I always say that you need to follow 4 steps not to get confused. You need to do palpation, percussion, auscultation, and observation. Always start from observation. So while we're still looking at this picture, let's talk about physical examination. Okay. So first thing that you need to do is observation. Okay, observation. What does the observation gives you? It basically gives you clinical picture. The same that you described already. Okay, next step that you need to do is the palpation. Palpation, tender mass, soft elastic consistency. What else do we have during the palpation? What's important, guys? No symptoms.
No pain.
Of Intussusception, let's make it like that. What I mean about that, I mean that there is no acute abdominal syndromes. Acute abdominal syndrome is absent. That means that there is no signs for appendicitis, no signs for peritonitis, cholecystitis, pancreatitis, or other kind of itis. So, okay, what do we have next? By the palpation, we can mention that it's usually painless. That's what gives us by the palpation. Percussion. What do we have by percussion? In this by percussion, we don't have a lot of information actually. Generally, abdomen will give us what? Which sound will give us the percussion in the abdomen?
There's fluid.
Tympanic
ringing sound.
Tympanic sound.
Tympanic.
And a bit dull sound in right iliac radius. Last thing that we have left is auscultation. Auscultation. By auscultation, what we will hear?
No bowel sound.
It's not completely absent in this case, but it will be
Or maybe
definitely
reduced.
reduced. So reduced peristalsis. That's what we will have in our physical examination. And with a combination of your anamnesis of the clinical picture and your physical examination, what you can say? You can say what? That physical examination doesn't give you a lot of good information. It gives you generally a healthy child with a serious, well, not a serious, but with problem. But you cannot define the problem by the physical examination. This tender mass that mentioned over here is not always palpatable. It is, it's supposed to be really huge invagination that you can actually palpate it. But you will have absence of symptoms of any kind of diagnosis that ends with itis. Plus, the thing is, usually palpation itself, usually painless, so the abdomen is soft and you're able to palpate the internal tissues easily. Other problems usually doesn't give you that. Percussion, the dull sound in the region, again, supposed to appear only if the invagination is really huge in size and the size of the child is small. Not always present. Reduced peristalsis can be by the different reasons. So you can say for sure that that is gives you the proper picture. So we have this case. What are we going to do with this child? What's our diagnostic?
Blood test.
X-ray with the
Okay, blood test. Let's start. There was mentioned in the beginning the blood test. So
Yeah.
what do we have as a diagnosis?
We do the full screen like CBC, you know, the FBC will show.
Okay, so
Yeah.
diagnostics. Okay, you can do CBC, complete blood count. And what are you gonna give to you?
There will be neutrophilia.
Nope.
No.
That will give you absence of any pathological. Oh well, there could be pathological appearance there if the child has something else except invagination. You understood what I mean?
Right. Okay.
So in this case, red blood cells will not be affected, white blood will not be affected, and generally it's mechanical problem. And the bleeding that have operating out, it's not a huge bleeding, it's not a severe bleeding that you will notice by the complete blood count. So no pathology in the complete blood count.
So,
Actually,
doctor, sorry, you know, with
Doctor,
yeah,
with what's going on, you know, there's obviously there will be inflammation where there's, you know, with the how do I explain that? with the invagination, there will be swelling around. That's why we can palpate the swollen intestine. Would that not have raised, like inflammatory markers at all?
What kind of inflammatory markers do you mean?
Do you mean C-reactive protein?
Yeah, and yes, yeah, would that not show in CBC at all?
Guys, what I can say to you, generally, there is no changes at all.
Okay.
The reaction, like you said, inflammation is supposed to increase the C-reactive protein, you said, right? And sedimentation rate, erythrocyte sedimentation rate.
Easy.
It will, if the
Doctor,
problem, yeah.
sorry, I thought there would be a raised white blood count though.
No, because the problem is not associated with the bacteria. The problem is not associated with the viruses. The problem is not associated with anything. It's a mechanical problem. Mechanical problem doesn't cause reaction from the blood. You will have in the blood and in the urine the side effects of this problem. So if you take urine, we talked about that it's more concentrated and the child has oliguria. So we can write like urine more concentrated. Okay, if we're talking about the biochemistry of the blood, what you will see in biochemistry? C-reactive protein, the ones that's responsible for the inflammation, will be normal.
How?
Because that is not the same, this inflammation.
Yeah, sorry.
This inflammation is minor inflammation, and this why C-reactive protein will be normal or slightly elevated, but it's slightly. You can't say for sure that it will be elevated a lot. Okay. What else there will be in biochemistry? You said by yourself, electrolytes. Electrolytes. You need to check, they will be shifted, definitely. And you need to see that, you need to check that. Generally, there is no other problems in the, yeah, thank you. Generally, there is no other problems in the blood. So laboratory in this case will help us to do what? To rule out other pathologies, to rule out other diagnoses. That's all that we can use in diagnostic with a laboratory. That's all that will be good for the laboratory. But we have instrumental diagnostic, additional instrumental diagnostic. And this instrumental diagnostic will be more useful for us. So what are we going to do in instrumental diagnostic?
An X-ray with the Richardson balloon.
Okay, that is good. Air contrast with the Richardson balloon. So what do we have here generally? We can put this into an X-ray film like that. So we have an X-ray film. On an X-ray film, we have only black and white color, and we don't see nothing. We put, usually we don't see nothing. But we take the balloon, insert it into a rectum of a child, inflate it over here, obturating the passage for the intestine. So, and we pump the air pumping the colon, and we can see that on an X-ray. Otherwise, it's invisible. Okay, by this one, you will see invagination. My question to you, what is the pressure that you need to pump by the Richardson balloon? Millimeters by mercury, guys. In this case, I'm talking about millimeters by mercury. For diagnostic, and if we visualize the invagination, we need to do the treatment. We can try conservative treatment. And then you'll pump up to 120, 130 millimeters. 140, 150. You can have ruptured intestine. So for diagnostic measures, you need to pump 80 to 90 millimeters. For treatment, 120, 130 millimeters. 140, 150 millimeters by mercury, that's risky for the colon to rupture. That's why I don't know the surgeons who will put this pressure into the colon of an infant to deal with the fecal peritonitis. Nobody wants that, trust me. Okay, that's the Richardson balloon. What other methods of diagnostic we can use?
Ultrasound.
Ultrasound, good idea. So we do, okay, one moment. Sonography. Sonography. What do we have in a sonography? What symptom it will have give us?
I read about the pseudo kidney sign and I read about the donut sign.
Okay, donut sign, that's one of the names that I know. So
I think they mean the same thing.
Sign. Another name for the donut sign is target and bullseye. So sonography gives us the same picture, Accept sonography. What else do we
have? Digital rectal exam.
Okay, digital rectal examination that will help us to visualize what? Digital rectal examination will give us two things. Digital rectal examination will give us two things. One, it will show you the color of the stool. When you take the finger out and look at the glove, you'll see this red jelly-like color of the stool. And second thing, you can palpate this area, invaginated area, from time to time, depending on its localization and depending on the situation that you face. Not always, but possible, theoretically. By myself, never done that before. For the infants, usually I'm doing Richardson balloon technique, more informative, less invasive, not so much, not so traumatizing to the child and to the parents as well, actually. And what else your digital examination gives to you? It gives you absence of inflammatory signs that is present in case of appendicitis or peritonitis, for example. So for diagnostic measures, yeah, you can do that. But I do not prefer to use it, actually. Okay, that is our diagnostics. And for example, you performing diagnostic, actually what you need to do, obligatory, mandatory, you need to do is, if you suspect invagination, is this thing. It's 100% necessary. Richardson balloon technique. That is specific method of examination for invagination. And the benefits is the fact that you can try to solve it, come to solve the problem conservatively without surgery. I think it's a good thing when you manage to solve surgical problem without surgery. Yeah. We stopped on the diagnostic with you. So you diagnosed the problem, you proved that the child has it with an X-ray, for example, with a Richardson balloon. What are you gonna do with it?
You treat the patient.
Yeah, definitely. How?
You reduce it.
So you or do the Richardson balloon treatment tactic, or if it fails, you do what? How to reduce this invagination?
Can you do a laparotomy?
You do surgery, yes. You're doing laparotomy. You need to bring the intestine out. What's the name for the surgery?
Is it called Hartmann's?
Hartmann's surgery.
Procedure.
Hartmann's procedure. Agree. Agree. It's not a popular name, but by the author, good. Actually, it's simpler if it's not Hartmann's procedure, but when it's called disinvagination. Like invagination, disinvagination.
That's easier.
So in this case, basically, you need to squeeze the intestine out one from another. And if you'll pull the intestine out, it's a risk that you'll rupture it. So you need to squeeze it out one from another. If you were in my portal, in the portal of our school, there is a video there about the procedure. If no, I will show it to you now. That is invagination in a classic place. You see that the color of the intestine goes from pale to pink. So that means that it's alive, just a bit ischemic. And the most distal part of the invagination is bluish. That's the area of ischemia, and that's the area that gives pain to the child, because ischemia brings pain. And if you notice, even when he touching the intestine, this part is edematous, so it is inflamed, according to other tissues, according to other parts of the intestine. That is a surgical procedure that's called the disinvagination. What is the second part of this surgery? What is the finish of this surgery? We need to make sure that this thing will not happen again. So what do we need to do? The second part of the surgery is called enteropexia. It's the fixation of the intestine. Entero is the intestine, pexia means fixation. You need, if you're doing surgery, it's better to make sure that you guarantee the result and you guarantee absence of appearing of this problem in future, absence of cases of reappearing of the situation. So you need to make surgical adhesion to from the intestine to the front abdominal wall from the inside. So this thread, this fixation with the ligature will prevent possible invagination. That's like that. Disinvagination with enteropexia. Disinvagination with enteropexia. Or Hartmann's maneuver with the enteropexia. Okay. That was
Doctor, sorry, can you repeat that again? So when you did this invagination, then what do you do afterwards?
You sutured the part that you took out to the front and abdominal wall, so it cannot slide back into. So you're preventing its movement. The intestine is supposed to be free normally, but in this case, better to fix it to prevent possible complications.
But what are the chances of it like going back inside?
The chances are 50-50. Can't say actually, because we always do enteropexia. One of my teachers told that if the intestine is like that, then it's already got used to be like that, and it's even good to do resection of the intestine. In case of infants, we cut the part of the intestine only if this distal part of invagination is not just ischemic, it's necrotized. It could happen if the parents waited extremely long. this distal part of an intestine can become necrotized, and if you will not remove it, it could rupture and cause peritonitis in future. In this case, you need to do the resection of the intestine and applying the anastomosis. Better if you're talking about small intestine end to end. If you're talking about colon and small intestine end to a side. If you're talking about the colon, then it's better to do side to side anastomosis. So depends where you found the invagination and this problem, you're doing the surgery.
Sorry, question, doctor.
Yeah.
I'd like to ask, when the intussusception occurs, is it likely to cause an adhesion? So are adhesions possible?
In
No,
this
okay.
case, by itself, by the procedure, usually no. But we're doing surgical adhesion, enteropexia at the end of the procedure, the end of the surgery. And in post-operation period, because we had operation in the abdomen, it could develop an adhesion as well. Adhesions, guys, is our next disease that we need to discuss today, actually.
And sorry, how long does it take for the tissue to get necrotized?
It's individual. I can't predict, and it depends on how deep it goes, how severe the edema is, how tight it's blocking the vessels, and different other reasons like the density of this blood, how the blood is concentration, dehydration of the blood, other additional pathologies of children. So I literally cannot predict.
Mhm. Mhm. Thank you, doctor.
In my case, I got this situation with invagination for a woman that had above 30 years of age, but the reason for her was the polyp, a single polyp that was in the small intestine, and the trick is that doesn't matter what kind of diagnostic we didn't manage to put the diagnose. We put this diagnose as a post-operational diagnose already. We did everything that we could to diagnose it. Ultrasound, X-ray, CT scan, barium swallowing tests, contrasted enemas, consultations with the neurologist. We did everything because her only one single complaint was about the pain in the abdomen, but no pathology revealed at all. We started to think that maybe she's figuring out the pain, maybe she's just imagining the pain. Psychiatric consultation said that no, she's not my patient, she's fine. She was mad that we forced her to pass the psychiatric test while she having abdominal pains. But literally, no, like endoscopy, gastroscopy, duodenoscopy, colonoscopy, no pathologies. The person is healthy, but the pain is present. She agreed for investigation. Surgery is the last option for diagnostic when you're doing surgery to put the diagnose. And during the surgery, we discovered invagination in the small intestine, in between the ileum and the jejunum, so in the center of the small intestine. Resection.
You think that's because of the age?
No, this invagination is 1 to a million case, 1 to a milliard case, because it's usually doesn't happen in adults. In her case, it was, let me show you. In her case, the reason was a single polyp, this one, a single polyp that were present in the intestine. Usually, if the person has polyps in the GIT, they are, well, almost everywhere. But in her case, endoscopy didn't reveal the polyps at all. And she had only one benign polyp in the small intestine. We resected this part of the intestine that was invaginated, and she recovered extremely fast, and everything was well. She went home on the 5th day after surgery, or even 3rd day after surgery, and then came back to remove the sutures. So that's it. The single polyp. The intestine recognized that as a piece of food trying to push it in, and instead of pushing in the food, it's pushing itself into and inverting the walls inside of the distal part of the intestine. Okay, so adhesions. So adhesions. What do you need to know about the adhesions, guys? They cause mechanical blockade. And my question to you guys is how we can recognize mechanical blockade of the intestine. Two things supposed to be present in clinical picture: constipation and vomiting. That's the symptoms of mechanical blockade. Third one, pain in the abdomen. Three things that's supposed to be present.
What's the third one, sorry, doctor?
Pain.
Okay, pain.
Pain in the abdomen. So what actually caused the adhesions, guys?
Fibrous tissue?
No. It's the adhesions themselves, right? It's fibrous, collagens, tissues, usually no serious vascularization there. It's a scar tissue.
Usually, you said the last question I asked. You said usually after surgeries like laparotomies,
Yes, that's.
they are prone to have adhesions.
But actually, my question is a tricky question because the real reason for adhesions is unknown. We know only factors for adhesions that are appearing and they are like, causing the adhesions, but you can't say they are the reasons. They are the factors because no original reasons. And the gels, the creams that we're using for the treatment of adhesions, they're not working. They're making the thing worse. Okay, but for example, you have a person that had previous couple abdominal surgeries, and now you're talking with him, you're doing the interview, he's saying to you that he feels pain in the abdomen, he didn't go to the toilet for 5 days, already, he vomit from time to time. The vomit in this case, well, with the partially digested food, and during your anamnesis, you discover that he had 2 or 3 abdominal surgeries before. So you suspect adhesions. How you can prove it that the person have adhesions?
We do X-ray, doctor.
That's a good way to diagnose it by the X-ray. You're doing ordinary observational X-ray, and you find what? What X-ray sign will reveal that the person or a child has mechanical intestinal blockade.
Would there be distension, abdominal distension?
Abdominal distension, yeah. But that is not an X-ray sign.
Okay.
The name for the X-ray sign, guys, who knows?
Like dilations of the bowel?
It will be, the bowels will be dilated, but what I'm drawing right now.
Gas bubbles.
Cool, that is completely correct. Now, how do you understand it as gas bubbles?
Because it's just small pockets of it.
Yeah.
Nice,
Drawing.
nice. This clinical picture called Cloydber's cups. Cloydber's cups. It's like a cup turned upside down. Teacup upside down. But I don't know what kind of imagination you're supposed to have to see a cup in this picture, but that's question to Cloydber, not to me. This picture on an X-ray reveals intestinal blockade, mechanical intestinal blockade. Only this picture will be enough to call to the surgery room and said like, get ready, we have mechanical blockade. That is an indication to do the surgery. In real life, let me try to find out the picture, how it looks like. That's it. So what do you need to see here? You basically visualize the clinical picture of the intestinal blockade. That's how it looks schematically. The loops filled with gas and the intestines filled with the contents. And you see the main thing on X-ray, you see horizontal line under these gas bubbles. The horizontal line. Look on the left picture, please. You have that's 1, that's 2, that's 3, 4, 5, 6, 7, 8, 9. In the bottom, I don't count that. So I see 9 different levels of the fluid. So fluid levels. That means that the intestine is definitely not working. The gas that produced by the bacteria accumulated at the upper parts of the loops of the intestine. It doesn't go nowhere. So the intestine is not moving, not working. In this case, the peristalsis will be also really decreased or almost completely absent. That's the Kleber's cups. But that is for any kind of mechanical blockade, even if the child have intussusception with a complete mechanical blockade. You can have this picture if you do ordinary X-ray examination without contrast. It could have this picture. But how you will understand that as adhesions? Okay, guys, it's a tricky question. You literally cannot diagnose adhesions at all. There is no method that I know that could be used to diagnostic adhesions. As a rule, they put it as post-operational diagnosis because usually we can suspect them before, but to prove that it's actually that, only during the surgery we can do that. Understood?